introduction. The topic which has been given to me is current management strategies. The diabetes is a complete, use the word, topic in itself. Squeezing it in 10-12 minutes is not an easy task. But I thought let me pick up some highlights which can just guide us about what are the management principles of diabetes. Who is at risk of our type 2 diabetes? So, ADA brings out these circulars from time to time. This is one such pamphlet which tells you have to do a risk stratification in every patient. How old are you? Are you a man or a woman? If you have had gestational diabetes, you have a family history, you have been had blood pressure, comorbidity, are you physically active? What is your weight category? These are some of the risk factors which one has to see before you look at diabetes and how to manage diabetes in a patient. And ultimately, in whatever case of diabetes you might have, whether type 1 diabetes or type 2 diabetes or gestational diabetes, ultimately the bottom line is lifestyle modifications. And lifestyle modifications, we know traditionally include diet, exercise, and along with that probably come drugs. And the drugs, when we talk about, we're talking about either oral hypoglycemic agents or insulins, or like you're having a hybrid eating combination of both. And ultimately, what is our aim? Our aim is that a patient's sugars should be within normal limit without the risk of hypoglycemia and preventing the complications which are associated with diabetes. And now with a lot of emphasis on bariatric surgery also, which Dr. Arun Prasad will guide us as always. And that will also be an integral part of treatment of diabetes in the future. The diet has to be patient-centered. Those days of giving patient a diet chart, having a 1600 calories chart or 2000 calorie chart is over. Now a person has to be asked for what kind of a diet you take. And depending on that, you kind of titrate that diet, which is useful for him. For example, telling a North Indian to have upma and idli or 200 grams of poha every day might be very difficult. But if you tell them to decrease chapatis from 3 to 2, or rice from a full bowl to half a bowl is still possible. And ultimately, as a clinician, we should look for at least 7% weight reduction in a patient and try to have as much normal weight as much as possible. Exercise is an integral part of any management. A young patient should be encouraged to do at least 60 minutes per day. And if you're a girl, then it is defined as at least 150 minutes per week without a break of a day or more. After at least 3 to 4 days of exercises. And all these things like aerobics or yoga or tai chi, they are useful. They do contribute towards exercise, but ultimately walking remains the easiest thing to do for most of our patients. Oral hypoglycemic drugs we all are familiar with, and if you look at the latest, now this is a chart which has been picked up from the 2023 guidelines, which have just been released by ADA. This is a complete chart which tells you how to use diabetic drugs, in which patients, etc. And if you look at the major headings, after the patient's lifestyle, you look at whether the patient has a heart condition, whether the patient has a heart failure, whether the patient has a CKD. In all these cases, different drugs are used in a different way, and some have been proven to be more useful. And ultimately, like I said, our goal is to have a normal diet, normal sugars without hypoglycemia, and probably preventing complications in most of the patients. And if, of course, you are not able to control with oral hypoglycemic agent, then insulin remains an option all the time. This is another master chart which has been taken from the same 2023 guidelines, which can be downloaded by everybody. And you can see the list of drugs which are available to us. When I started practice in 1990, we used to have only 2 drugs available. One is biconides and sulfonylureas. And now we have at least 7 to 8 groups like SGLT2 inhibitors, GLP-1 analogs, DPP-4 inhibitors, thiazolidinediones, along with alpha-glucosidase inhibitors and all. So the advantages, the pros, the cons, they all have been listed in this master chart. And I think most of the clinicians are familiar with this. I think in 10 minutes we can't squeeze in everything. But SGLT2 inhibitors and GLP-1 analogs have become more and more popular. And lately, since they have become more economical for most of us, so I think we can use in almost all our patients nowadays. Insulin has always remained a cornerstone of management. Insulin was discovered in 1921 and until 2023-22, we are on the verge of 23. We still insulin remains a good drug for us all the time. So the trick of the trade about using insulin is whether you want to give one prick, two prick, three pricks, or four pricks. Ideally speaking, the one which matches maximum with the patient's physiological weight is what we know as a basal bolus. So we give 3 short insulins before each meal, along with the basal insulin to take care of our basal sugars which are high. And then once you're controlled, you can shift on to twice a day insulin or once a day insulin or a basal insulin, depending on how you like. So I think there's another master chart which probably tells you about how to use insulin in various patients per se. And ultimately, like I said, what is our aim? To decrease the cardiovascular disease risk. After all, diabetes is one of the cardiac risk equivalent. Hypertension should be controlled. The lipid management has to be there along with that, and antiplatelet agents always remain cornerstone of management for any cardiovascular disease patient. The risk for the eyes has to be decreased. The retinopathy, the nephropathy, the neuropathy, the peripheral vascular disease, all what has been discussed till now, they all have to be controlled, and the cornerstone of management remains again management of diabetes per se. Obesity has become a very major risk factor nowadays, and more focus is on obesity. And I think now we have anti-obesity drugs also available in US, and they're also coming to India. And amongst other medicines, dulaglutide and GLP-1 analogs are supposedly drugs which are used even for obesity. But drugs are not the main thing. Ultimately, it is a motivation for the patient to manage by physical improvements, and probably if you're above a certain level, then we're talking about metabolic surgery. And bariatric surgery, metabolic surgery, they go hand in hand. And ultimately, I would say if a patient has a BMI above 35 or 40, they should be encouraged for metabolic surgery. The results are for all of us to see. And I think more and more patients are opting for metabolic surgery if the patient has above 35, 40, because it's highly unlikely that just by controlling the patient's sugars can things be controlled. So apart from all the points which I have touched about, nowadays other things about management also include the new kind of gadgets which have come. We have insulin pumps available to us. We have those freestyle Libra in which we kind of do a self-monitoring of sugars. We have a continuous glucose monitoring in which it has to be between a certain levels. So I think all these new gadgets have to be used in our practice so that we can give the best possible chance for a patient to manage diabetes. So just to summarize what I've talked about in last 8-9 minutes, ultimately diabetes is a multidisciplinary approach. It is not a single person's approach. It includes a nursing educator, diabetes educators, dietitians, podiatrists, motivations, and I think psychosocial approach is also extremely important in most of the patients, because ultimately diabetes affects the whole family. So it is not about managing a patient only. It affects the whole family. The whole family has to support the patient who has diabetes, and that is also an integral part of management. So lifestyle modification is something which kind of continues. I have patients who have been coming to me for 20 years. Now, if I'm taking a consultation for 20 minutes, probably I'm talking about lifestyle modification for 15 minutes. And I think just changing the medicines or insulin probably just takes me 5 minutes. So we have to constantly impress upon the patients the need to have a lifestyle modification all the time. The diet has to be monitored as much as possible. Exercise has to be encouraged in patients. The new drugs keep on coming. The feasibility of using the drugs, new literature, and ultimately, like I said, we have to use the drugs according to the best of the patient's needs, and also the patient's economical viability also has to be considered. Metabolic surgery, I think we doctors should, especially medicine people, should kind of shed the ennui of promoting patients for metabolic surgery. It has been very, very effective, and if used in good hands, I think it can make a huge difference. Ultimately, our aim is that the complications of diabetes, whether it's a neuropathy or a nephropathy or a retinopathy, they all should be avoided so that patient can have a healthy lifestyle and can have as normal a life as much as possible. Thank you very much for a patient hearing. I'm sorry for this virtual thing. I wanted to be there, but due to circumstances, I couldn't come. I would like to take any questions if anybody wants to pose any. I hand it over to the forum.
Dr. Atul, I'm Dr. Aram Chowda, I think you know me. Dr. Atul, very nice presentation. No doubt, holistic approach must be there. You require the dietitian, other educators to treat the diabetes mellitus. Drug is, no doubt, there is a lot of the flood of the drugs in nowadays, in the Mediterranean. We are confused which drug we have to use. But lifestyle management is very, very important. Diet and exercise, all are important. If you see, I must emphasize on the adherence and the completion of the treatment, because patient leave the treatment in between. That's the main cause, 75% of the complication, the non-adherence to the treatment. So we must educate the person how to regulate the treatment and diet management and the exercise management, all the management. It should be a holistic approach. It is a teamwork. Not a doctor cannot treat the diabetes only. Thank you.
Just a small inquisitive thought process. We already delayed, and thank you, Dr. Rakesh Gupta, for a very important talk. There are a lot of advertisements, especially on the Facebook and YouTube, of the reversal of diabetes. A quick, very quick comment of 30 seconds or 1 minute, whether it is actually possible or it is just a ad process.
I think the answer to the question is, if you pick up a patient at the pre-diabetes or the very early diabetes stage, then I think with very intensive diet control, and it was published in BMJ a couple of years ago, there is a possibility of reversing, but that requires a very high level of motivation. So patient, if he's on an 800 or 1000 calorie chart, and patient exercises very vehemently, he should be encouraged, and there is a possibility of reversal. So I think I would like to encourage my patients at the very early stage, but I will not show false promises to my patient who has been diabetic for too long. Dr. Arun Prasad, who is probably going to tell us about bariatric surgery, may be very interested in telling us about the reversibility of diabetes, because I have seen quite a few patients who have undergone metabolic surgery. They have reversibility, and HbA1c has come down from 8 to even 6 and 5.5 in a lot of patients. So reversibility is an option at an early stage, or a very intensive motivated patient, but not for most of the patients.
Even you have to see in the pre-diabetic stage, because the micro as well as the macro, both components start from the pre-diabetic stage also. I think we should show in the pre-diabetic stage also.
So the pickup at a very early stage and motivating a patient is a key to it.
That means all more of an advertisement rather than reversal. There's no actual reversal of diabetes. Okay, thank you very much.
Ads are meant for things which don't sell much.
Thank you very much. So we move on to the lunch part, but before that we have to give a moment to Dr. Rakesh. I will be handing over your memento at the Apollo Hospital itself later on.
Thank you, Vivek.
If possible, please join in the evening time around 6 p.m. so they stay with the valedictory function. We'll be waiting for you if possible.
Thank you. Thank you. Bye. See you.
Could you allow screen sharing?
So we now would be quickly breaking for food. Thank you very much. So I request whosoever have spoken here, a panelist or chairpersons, would stay back post lunch also. And so we will break for the lunch now. And but we have to come back exactly at 2:40 p.m. because next talk will be. Dr. Prasad is already here. Okay, I thought he will be talking because I was told that he will be talking post lunch. So Dr. Arun Prasad, welcome to the IECR meeting. You have been between the two operation theatres. So because you are doing a bariatric surgery, you are doing obesity treatment. So I think let us cancel the lunch. No, that is not a good idea. Taking food is very important. And Dr. Prasad, please introduce yourself. Let me introduce. He's a laparoscopic surgeon of repute. He's doing a lot of cases. And but he's also at the same time doing bariatric surgery to reduce body weight. And that is sometimes very important, not only for the lifestyle, but also for overall lifespan. Because once you are obese, you have more chances of diabetes, heart risk, coronary artery disease, angina, acute MI, and of course other problems. So Dr. Prasad will be talking for next 10 minutes about the bariatric surgery on virtual mode. Thank you.
Thank you, Dr. Vivek Gupta, for those kind words. I'm sorry I could not be there in person because my earlier surgery took too long, and I'll not hold you people back from lunch and try and be as quick. Most of the concepts have already been cleared by Dr. Rakesh Gupta in the previous talk. And when we talk about metabolic and bariatric surgery, we are talking about how risk of living with obesity versus risk of surgery. And this is what is important to understand, that risk of living with obesity has actually more than the risk of surgery. We have options of diet, pills, exercise, endoscopic treatment, and surgery. And also these days, the insurance company is approving bariatric surgery, and this has been there since October 2020. And many of our patients are now availing the benefit of insurance also. So how safe is metabolic and diabetic surgery? It is as safe as any other common procedures when we talk about cholecystectomy, appendicectomy, hysterectomy. And in fact, the complication for gastric bypass is about the same for laparoscopic gallbladder surgery or hysterectomy. And hospital readmission rates are similar to an appendix surgery, and the month-day death rate for metabolic or diabetic surgery is 0.30%, which is the same as total knee replacement, and about 1/10 the risk of cardiovascular surgery. So we have various options available: endoscopic treatment like balloon, endoscopic sleeve, and we have surgical options of laparoscopic, robotic, and revision surgery. So when we talk about bariatric endoscopy, this is for patients who are not obese enough to qualify for surgery, not fit for surgery, and we do this. We have a procedure which is the gastric balloon. As you can see there what we do is by endoscopy, we put in a gastric balloon that gives the patient a sense of fullness. And after 1 year, when we remove this balloon, we hope that the patient's eating pattern has changed and they are able to maintain the weight loss. This is the simplest of all the bariatric procedures that we do, which is the gastric balloon. The next is what is known as an endoscopic sleeve gastroplasty. And here what you can see is that I have put in an endoscope into the stomach, and I'm actually going to stitch the stomach wall together like gastrectomy surgery. Again, procedure is good for those who don't want surgery. It leads to a 15 to 20 kilograms of weight loss because of the reduction of the size of the stomach. And what you can see there is how the endoscopic suturing device is actually working. It's like a sewing machine basically. So in bariatric surgery, we actually manipulate normal organ systems. And the mechanism is malabsorption, calorie restriction, energy expenditure, change in eating behavior, and more importantly, we have some chemical factors which are involved. So the initial thought was like sleeve gastrectomy is a restrictive procedure, less calorie intake, but now we know that it causes accelerated gastric emptying and distension of the antrum, whereby the satiety is better and hunger is less. There are various hormonal studies which have shown various reasons why we get weight loss, and as Dr. Rakesh Gupta was mentioning, the reversal of diabetes, and that's to do with the GLP-1, which is indigenously GLP-1 does is it the beta response workload of the patient and increase so that better glucose metabolism takes place. And this is best seen by this graph which you see. On the left, you can see how the level goes up both with IV and oral glucose. And on the right, if you see the insulin levels or the C-peptide level, it goes up with oral glucose, but not with IV glucose. And this is what is the incretin effect, that the oral glucose stimulates something in the intestine. And in diabetes type 2, this gap is narrow. So what happens is that there are factors which are there in the duodenum, and this is not produced because of the bypassing of the food or fast acceleration of the food through the small intestine. There is a hindgut theory which shows how the food, if it reaches the distal ileum quickly, it increases the GLP-1 levels. So combined effect of that, we have also changed bile acids, easy transit to ileum, there is malabsorption, alteration of gut flora, and various kinds which lead to these effects. We have two types of bypasses. Many of you would know that. One is a Roux-en-Y bypass, and the other is what is known as a mini gastric bypass. And we choose between the procedure based on the patient requirements. This is how we do the surgery. As you can see, this is a robotic, and then what we do is the procedure whereby we stitch a stomach pouch into the intestine, and this will lead to the food passing quickly from the stomach pouch into the intestine, thereby reducing the anti-incretins and increasing the incretins and GLP-1 GIP levels, which lead to weight loss and improvement of diabetes and other metabolic issues. So we have again the bariatric surgery by laparoscopy or by robotics. We have both at our hospital, as most of you would know, and both have their advantages. The robotic is better for the super obese and revision surgeries, however, it is more expensive. What you see is, and this is how the robot looks like. That is the robot which is wheeled in towards the patient's head. This is known as docking of the robot, whereby we have connected the robot to the instruments which are going inside the patient. Surgeons are the also there and is able to perform the surgery there. It's more precise, less blood loss, faster recovery, less complications. This is the patient in the recovery after the surgery, being shifted to the room 1 hour later, after the surgery. Same patient, this time before surgery, then he sent me a picture wearing the same jeans. Later on, 2 years later, when he came to the OPD, he was wearing new jeans. So this is the kind of result we get by doing bariatric surgery in the right patient. We develop bariatric surgery by reading. There are conferences, live workshops, people observe, then I go and train surgeons at their hospitals. Finally, independent surgery. Currently, all over India, we have around 500 bariatric surgeons doing bariatric surgery. So we have various procedures like starting, as I said, gastric balloon, sleeve gastrectomy, Roux bypass. We prefer bypass for metabolic issues. Patients with GRD, we again do bypass. People who have liver or kidney failures or other systemic problems, we prefer a sleeve gastrectomy. And revision surgery, these are the procedures which we do based on the requirement of the patient. That's the kind of BMI related choice of procedures which we take. So to summarize, prevalence of obesity and obesity related disorders is on the rise in adults, adolescents and pediatric population. Hence, this problem is unlikely to be resolved in the near future. In a perfect world, primary prevention through an exercise would alleviate the need for surgery till we begin to see success with primary prevention or develop equally effective medical management. Bariatric surgery will remain an important and reasonably safe tool in our armamentarium for treatment of obesity. Thank you very much. I'm sorry to keep you people from your lunch. If you have any questions, I'll be happy to answer.
Thank you, Dr. Arun, for the nice presentation. No doubt pediatric surgery is very, very important to treat the diabetes. No doubt in it. But we, in this way, we realign the things, I think, to treat the diabetes. My 2 or 3 patients really we control the diabetes after the pediatric surgery in the north area. I am Dr. Arun Chavra. Yeah. Thank you very much. Over to Dr. Vivek.
Yeah, Dr. Arun Prasad, I compliment you for doing good work for the country. And you see, all the surgeons or cardiologists or angioplastics or clinical cardiologists, they all save lives. I think our population, especially the general population, have to understand whatever is the treatment, either by private hospital doctor or by government hospital doctor, they both are equally important, and they might have to pay in private setup, but finally it is a service. Service can be free or it can be paid, but finally it is a service of life-saving in whatever way. So this is what I always tell all the media persons. In the evening also I'll speak the same thing. And Dr. Prasad, I would like that you can join at around 6 p.m. for the valedictory function once you have finished with your OT work. So thank you very much. Despite all the efforts, the bariatric surgery is getting more and more common, but not that common which we expected. There are always pitfalls, which you've already told. And but of course, these are important part of surgical procedures. One thought process, although very late, is coming in my mind. You know the singer, Pakistan singer, now is Indian national, Adnan Sani. He once spoke in a public platform that he reduced his weight without bariatric surgery. So how far is that correct? Any idea?
See, from what I've heard, he had his bariatric surgery done in Brazil. But
he was too much overweight, and suddenly he became quite thin within 2 years. So, but he said that he has not done any surgery, it is only diet. I don't know. So it's always, unless you see yourself the incision, you are not sure. Thank you very much. And let us move to the next session of lunch. I am sorry to tell that we have to reduce the time, because next topic is from Dr. M.K. Das, who is a past president of Cardiological Society of India National. So after that, but we want to squeeze the time of lunch to 20 minutes. So let's go on the lunch and come back. And Dr. Prasad, please, whenever you have time, please listen to the talks in the next sessions. So we will go and come back. That means just going and coming, touching the food and coming back. So time is now 42:33. So let's come back at 2:50 or 2:53, 20 minutes. Thank you.